Okay, let's talk about a true surgical emergency. One where the clock isn't just ticking, it's screaming. We're diving into the perforated duodenal ulcer. This isn't just a bad stomachache, it's an absolute catastrophe unfolding inside the abdomen. And believe me, how we act in those first few hours can mean the difference between life and death. Let's get right into it.
Right, before we go any further, just the essential reminder. This is all for educational discussion. When you're with a patient, you always follow your local clinical guidelines and hospital protocols. This is about sharpening our thinking, not replacing your training.
So here's our game plan. We're going to walk through this whole clinical journey. First, we'll get a handle on the emergency itself. Then, how to nail the diagnosis fast. We'll cover the immediate life-saving resuscitation steps. After that, the surgery itself. And finally, we'll talk about the crucial follow-up to make sure this never, ever happens again. This is our playbook for the race against sepsis.
So, what are we really up against here? Let's break down exactly what's going on and why this situation goes from bad to life-threatening in the blink of an eye.
A perforated duodenal ulcer, or PDU, is basically a hole that is burnt all the way through the wall of the duodenum. And the result? It's a disaster. You've got stomach acid, digestive juices, food, and bacteria all pouring into the sterile space of the abdomen. This kicks off a massive chemical firestorm, which quickly becomes a raging bacterial infection or peritonitis. And that is a direct, one-way ticket to septic shock and organ failure if we don't intervene.
And this is not an exaggeration. When a patient looks you in the eye and says this, or describes a sudden tearing pain that is a 10 out of 10, your mind needs to go here immediately. This isn't just a symptom. It's the classic 5-alarm fire bell that signals a visceral perforation has likely occurred. It's the starting gun for the whole emergency.
Okay, so our suspicion is sky high. Now we go into detective mode. We need to rapidly gather the clues to confirm what we're thinking and get this patient on the fast track to the OR.
The patient's story is where you'll find your first big clues. Beyond that insane pain, ask if it radiates to the shoulders. That's a textbook sign of air under the diaphragm irritating the phrenic nerve. About 3/4 of these patients will have a known history of peptic ulcer disease, but remember, that means a full quarter of them might not. So you have to dig for the big risk factors. Are they taking NSAIDs, steroids? Are they a smoker? Have they been treated for H. pylori?
Then you get to the exam, and frankly, it's often dramatic. The patient just looks sick. But the money is in the abdominal exam. Board-like rigidity isn't just a fancy term. It means the abdomen is involuntarily clamped down so hard it feels like a plank of wood. You can't fake that. That, plus major rebound tenderness and a silent abdomen on your stethoscope, is the classic triad of peritonitis.
So the story fits, the exam fits, your clinical suspicion is through the roof. But you need proof, right? What is the definitive step you take to lock in this diagnosis and get the surgeons on board? Imaging, of course. We start with a simple erect chest x-ray. It's fast, it's easy, and we're looking for that beautiful, or terrible, crescent of free air under the diaphragm. It'll catch it about 70 to 80% of the time. But if that x-ray is negative and you still think this is a perf, don't hesitate. You go for the gold standard, the CT scan. It's almost 98% sensitive. It will find even the tiniest pocket of air and can often pinpoint the leak for you.
Now, this next part is absolutely critical. Diagnosis and resuscitation do not happen one after the other. They happen at the same time. While that patient is going for a scan, you are already fighting the war against shock. You're pulling them back from the edge. This is your immediate action plan. Think of it as winning the first lap of the race. Airway and breathing. Get them on high-flow oxygen. Circulation. 2 large-bore IVs, wide open with fluids. They are incredibly dry. Get broad-spectrum antibiotics in them within the hour. Control that horrible pain with strong opioids. Drop an NG tube to suck out stomach contents and stop feeding the fire. And get them hooked up to a monitor. This is Damage Control 101, and it starts now.
All right, we're stabilizing the patient, but that's just buying us time. The only real solution here is source control. We've got to get to the operating room and plug the leak.
The surgical fix is almost always an omental patch repair, also known as a Graham patch. We're essentially using a piece of the patient's own fatty omentum to plug the hole. Now, if your patient is stable, the standard of care today is to do this laparoscopically. It's minimally invasive, means less pain, and a quicker recovery. But if your patient is crashing or the perforation is huge, there is absolutely no shame in doing a big open laparotomy. The goal is to get in, get control, and wash everything out as quickly and safely as possible.
Now here's a really key point, especially for anyone who trained a while ago. We've moved on from the days of doing big acid-reducing surgeries like vagotomies during the emergency operation. Why? Well, because our medications, especially proton pump inhibitors, are just so darn good now. The modern approach is damage control. Just fix the hole. We let the powerful medical therapies handle the underlying ulcer disease after the patient is safe.
The surgery's done, the patient's in recovery. But our job is far from over. What we do next is just as important, both for getting them through this admission and for making sure we never see them for this again.
So post-op, many of these patients are sick enough to need a stay in the ICU or a high-dependency unit. We'll keep them on IV PPIs to help that patch heal and continue IV antibiotics to clear up the peritonitis. That NG tube stays in until their gut wakes up, then we can start to slowly feed them. And right away, we begin the conversation about lifestyle changes, like quitting smoking.
This one is non-negotiable. I want you to burn this into your brain. Every single one of these patients must be tested for H. pylori. And if they're positive, you treat it until it's gone. This one step is probably the single most effective thing we can do to prevent another ulcer. It's mandatory.
And here's the other absolute must-do. You have to address the NSAIDs. Medications like ibuprofen and naproxen are major culprits. They need to be stopped, permanently if possible. If a patient absolutely needs an anti-inflammatory for something like severe arthritis, that's a serious discussion about safer alternatives, and always with a PPI on board for protection.
And finally, why all this urgency? Why the talk of a race? Well, look at this number. For an older patient with other health problems who doesn't get to the hospital for a day or so, the mortality rate is over 30%, 1 in 3. That is a terrifyingly high number, and it's why every minute, every correct decision truly counts.
So the next time that call comes in, the sudden, crushing epigastric pain, the board-like abdomen, you'll know exactly what's happening. The race against sepsis has just started. The only question is, are you ready?